Hey everyone, welcome to our final mini lecture in the hallucinogens unit. Today we're talking about PCP and ketamine. So first off, phencyclidine or PCP was developed as an anesthetic initially. It seemed promising at first as it didn't have a risk of producing respiratory depression as many more barbiturate-based anesthetics do. However, this produced unusual and sometimes severe reactions, which is one of the reasons why it saw use as a drug of abuse subsequently. Ketamine was developed after this as a safer, more shorter-acting alternative, which still sees clinical use mainly as a pediatric anesthetic or in veterinary practice, so it's used for kids and animals. This does still see use as a street drug. Both ketamine and PCP do for the euphoric and dissociative properties. Though it's not very popular in most circles, this never rose to the level of popularity of things like opiates or marijuana or cocaine. And I'll talk about exactly why this wasn't as popular as a street drug. So, in terms of use, PCP is generally obtained in forms of a powder or a pill, and from there it can be taken orally, snorted, injected, or smoked. The potency and duration of the effect is, of course, influenced by the route of administration, like everything else that we've talked about. Ketamine, on the other hand, is typically diverted or stolen from medical supply or veterinary supply. It can be administered in a similar way. It can be injected as it is, or it can be dried out and converted into a powder form, which can be administered in a number of different ways. This is known by street names of K, Special K, or Cat Valium, despite not operating by the same mechanism as Valium. We'll talk about the mechanism later on. So what happens with the use of this drug? One of the signature components is a feeling of detachment from the body, feelings of vertigo or floating, numbness, entering of a dreamlike state, and there's also some affective reactions including drowsiness, apathy, loneliness, negativism, and hostility, alternatively euphoria, and inebriation. So you might notice that some of these things are sort of opposed, negativism or hostility as opposed to euphoria. This, like some of the hallucinogens we spoke about earlier in this unit, depends a lot on the individual and the state of the individual going into things. Whether or not they become hostile and agitated or experience euphoria depends on a number of different factors, including the dose, individual variables, the setting, etc. So many of you have probably heard the term K-hole. This is what's produced at moderate to high doses of ketamine. At low doses, ketamine produces similar reactions to PCP. However, at anesthetic doses and higher, a dissociative state, which is sometimes called dissociative anesthesia, has many diverse reported effects. This is often referred to by users as the K-hole, sort of like falling down a hole with ketamine. And this can be either uplifting or terrifying. Again, like many of the other trips that we've talked about, this depends on many state factors. So many of the subjective experiences reported by ketamine users are listed here in this table. Things like loss of sense of time, a sense of being at one with the universe, visions of supernatural beings, altered perception of body consistency. So lots of strange sort of sensory and experiential effects that may not be altogether pleasant, depending on the individual. So how does this work? Well, this mechanism might seem somewhat familiar, as we have used a drug that is somewhat similar to this in lab. PCP and ketamine both are non-competitive antagonists of NMDA receptors. You can see they have PCP has a binding spot right here. Ketamine has a similar mechanism, so in a similar fashion to MK801, these antagonists will sit in the ion channel and block the flow of ions. So they are non-competitive because they're not acting at the principal glutamate binding site. They are doing something at a different site, but altering the function of the receptor. So this has all the effects that you would expect it to in terms of altering NMDA receptor function. Just like MK801, it's going to not allow sodium and calcium to enter when glutamate binds. So you might be wondering what gives rise to these strange effects, given that it's such a, ubiquitous receptor type. The blockade of NMDA receptors in the cortex and hippocampus is probably what's contributing to cognitive deficits caused by PCP and ketamine. So there's a lot of sort of cortical higher order function that's being disrupted. That we'll talk about some of those acute effects in just a bit. But a lot of these effects are due to cortical and hippocampal disruption of normal function because of the dense expression in NMDA receptors in those regions. So another mechanism by which this operates is an increase in presynaptic glutamate release within the cortex. So this is sort of a complex mechanism of action. So at one site, it is blocking ion entry through NMDA receptors, and through a completely different mechanism that we're not really going to go into, it is going to increase presynaptic glutamate release. So it's going to increase glutamate transmission. Of course, not at NMDA receptors, because NMDA receptors are blocked by PCP and ketamine. So sort of two things that are happening are blocking of NMDA receptors through this non-competitive mechanism and an increase of glutamate release, which is going to increase glutamate signaling at non-NMDA receptors. So something of interest with these types of drugs is they produce a schizophrenia-like state in certain respects. All subjects using these drugs show cognitive disorganization as an acute effect. Difficulty with focus and paying attention, problems with abstract thinking, problem solving, and halting speech. These are all things that are characteristic of people with schizophrenia. So PCP effects are often compared to the symptoms of schizophrenia for that reason. This is one of the reasons for the drug's waning popularity. While it might be fun to dissociate and have a euphoric state, it's probably very unpleasant to have all of these symptoms of schizophrenia at the same time. Another facet of that is things like ketamine are a popular animal model for schizophrenia because it induces many of the same behavioral patterns. So it's a useful mechanism to study schizophrenia-like behaviors in an animal research model. What we've learned from this is sort of led to the development of the glutamate hypothesis of schizophrenia. So a lot of thinking about schizophrenia is traditionally centered around dopamine signaling, but it seems like glutamate may also be important, as hypoactivity of glutamate system is key in pathogenesis. So we see hypoactivity, not enough activity that is in the glutamate system, and it produces effects that look a lot like what we're seeing here. And in post-mortem examination of brain tissue from schizophrenic patients, we see reduced NMDA receptor expression. So that sort of mimics that effect too, right? Because this drug decreases NMDA receptor activity, and in schizophrenic patients, we see less expression of NMDA receptors. In addition, people with schizophrenic symptoms who take drugs like this tend to get worse. So, are PCP and ketamine reinforcing? In fact, yes, they are highly reinforcing. A wealth of self-administration studies across many different species, including humans, show that this is indeed reinforcing. What also speaks to this is high abuse potential, right? These drugs have a high abuse potential. People tend to use them for recreational purposes, so they are reinforcing. Both ketamine and PCP activate midbrain dopamine neurons, so the mesolimbic dopamine system is active. That shouldn't come as a surprise. Pretty much every drug we're talking about activates that if it is reinforcing. Particularly, this increases dopamine release in the prefrontal cortex, so lots of alterations to the neurochemistry of the prefrontal cortex with these drugs. Rats also will self-administer for PCP directly into the nucleus accumbens, which is interesting because it means that a non-dopamine mechanism also must exist. While this drug does increase dopamine release, we know that. We also know that because direct administration into the accumbens is reinforcing, produces continuation of that behavior, we know that reinforcement can be produced outside of the dopamine system as well. So let's talk briefly about dextromethorphan. This is a common ingredient over-the-counter cough medicine. This is also a non-competitive NMDA receptor antagonist, so like PCP and ketamine. So this is metabolized into its active form of dextromethorphan, which is what's producing all of its effects. This is something that is somewhat commonly diverted and abused, as it's an over-the-counter medication that has potential psychoactive properties. This can prove dangerous, as other active ingredients contained in the medication can prove toxic in high enough doses, in addition to the risks that you're taking with high quantities of the NMDA receptor antagonist to produce the dissociative state. Things like antihistamines or anticholinergics, as well as expectorants, things that are often contained in cold medicine, at significantly high doses can pose health risks of different sorts. This produces similar effects to classical hallucinogenic drugs. So it'll produce similar patterns of effects as what we've seen already. For this reason, you might see that sometimes when you go to buy cold medicine, you have to be of a certain age to buy it, depending on what state you're in, or there may be a limit of how many bottles that you can purchase at once because of the risk of abuse. While this is still completely legal to purchase, it is something that regulatory bodies in the US are watching. So, risks of use of drugs like PCP and ketamine. You can have some things that are actually outside of the brain, so urological problems like bladder pain and incontinence can be produced. Gastrointestinal disturbances in general from continued use. Deficits in memory and other cognitive functions that can be long-term, so not just the acute effects that you see during the actual use, but long-term deficits in memory and other cognitive functions, likely related to gray and white matter abnormalities. So what we have here is a depiction of slices taken from a rat prefrontal cortex after 20 days of daily administration of ketamine. We see here the healthy control subject, and in the lower image, the subject that was administered ketamine for 20 days. So you can see here the amount of difference in cell death produced over the trial, with a great amount of cell death produced in the group receiving ketamine. We also know that apoptotic cell death can occur in nervous tissue developing rats and monkeys who are administered ketamine. And this is especially troubling given that ketamine is often used as a pediatric anesthetic. That said, GABAergic anesthetics also are prone to causing apoptotic cell death, so there's not really a better option. So there are some other therapeutic potential uses for these sorts of drugs. While they didn't really see great success as an anesthetic because it produces often an agitated and averse state in the patients, what we do know is that single IV dose can produce rapid but transitory or temporary improvement in clinically depressed patients. The mechanism for that isn't really well understood, but it can serve as a really great stopgap for somebody who is in a really bad place and is put on a typical frontline treatment like SSRIs. SSRIs have an induction period of about 2 weeks before real improvement starts to take place. And if you have someone who is at real risk for self-harm or potentially suicide, something that is a more rapid intervention is really desirable. So giving ketamine as sort of an acute reversal of these symptoms while the SSRIs are doing their thing could be a potentially useful intervention. It's also tempting to be used as a non-opioid analgesic for pain conditions or for peri or post-operational pain. There's also potential application of drugs like ketamine in reducing opiate drug tolerance, as opiate drug tolerance is also mediated in part by NMDA receptors, so ketamine may have the ability to reverse that opioid tolerance. Okay, that is it for our discussion of PCP and ketamine, and concludes our discussion of hallucinogens in general. We'll see you next time.